Okay, so we have many people already in the room. So let me welcome everyone to this talk. It's great to have you all here today for the last of the ODI, the LSE series, which I think have been a great opportunity to join forces, join ideas, and have the two communities come together. I surely hope that in the future we can find ways of finding together which are not just online. But I also think that this has led us some information on how we can do things excitingly online as well and in collaboration. So for the last one, we have a discussion about health, poverty, and human development with three speakers. Sabina Alcaraz from my department at Oxford, Ernestina Coast from Development at LSE, and Rishita Nandagiri, with apologies for my pronunciation, also at LSE. Each of them will speak for 15 minutes and then we will collect questions. So Sabina, the floor is all yours.
Thank you so much. And thank you to all who are viewing. I'm really looking forward to the discussion and the interaction afterwards. What I will do is just share a little bit of a piecemeal overview of some of the different intersections that we've been exploring in terms of multidimensional poverty, which our research group works on, and different aspects of health deprivations, both direct COVID infections and also underlying conditions of poverty that, as we know from the UK, often predispose people to have a bigger impact from the current pandemic. This is joint work with colleagues from my team. But I'd like to begin with a quote from Amartya Sen in a Financial Times article he wrote in April, where he quoted the Queen's reference to "When We Meet Again," that song. And his suggestion at that time was, when we are managing the pandemic, we do so with a concern for equity, then that could considerably lessen the unequalizing impacts of the pandemic, and maybe even rescue some more equalizing outcomes from it. And I think it's with that motivation that we try to go into the data on multidimensional poverty and on health to think of what kind of information might be useful to inform equalizing responses or the concern for equity by policy actors so that they are empowered to act more actively. So I'm going to begin by presenting just some analyses that use a global database that we construct, Ushkanagratnam Nikolai Sepa at OFI, and larger teams for changes over time, that covers 5.7 billion people and 101 countries in the 2019 release. And then I'm going to move to national measures of multidimensional poverty that governments have as official permanent statistics, and showcase some of what governments are doing in their own cases. And I'll end with a quick and happy example from one of the countries that will be releasing in terms of trends in global multidimensional poverty over time in July with UNDP. So the global MPI already has cleaned data for 10 indicators for each of the countries for which these data are available, using mainly demographic and health surveys and multiple indicator cluster surveys. And it's if anybody in the household's undernourished, if a child has died, if nobody has completed 6 years of schooling, or a child is out of school until class 8, and if they're deprived in living standard indicators like water, sanitation, clean energy, electricity, housing, or assets. And we identify a person poor if they're deprived in 1/3 of the weighted indicators, 1/3 of these dimensions. And of the 1.3 billion people that we identify as poor, 98.8% of them are deprived in at least 3 things at the same time, and 83.5 in at least 5 deprivations. So 5 of these 10 indicators, they're carrying the deprivations at the same time. And so the multidimensionally poor already have a deprivation load, and then COVID-19 comes in. And for many of us, it has been a shocking exposure to a new threat. It's a time we will never forget. our working lives and personal lives have changed. But for the people who are already multidimensionally poor, COVID is another addition to their already extensive deprivation load. And so our hope is that those who are working on COVID responses in the health sector would also be able to understand this other element of multidimensional poverty in their responses. So here are a few ways of doing so, and they're illustrative. One is to identify people who are at higher risk. And they might be at high risk because they are deprived in nutrition. Somebody's undernourished, they don't have clean water, and they don't have clean cooking fuel, so are at higher risk of acute respiratory infections. And across our data set of 5.7 billion people, 3.6 billion have at least one of them, and 470 billion of all of them. And so these people perhaps would be at a higher risk if the pandemic came to their doorstep. And so in April, when we issued our first policy briefing, we mapped the levels of people who are deprived in all three and multidimensionally poor, and we mapped those against the COVID prevalence at that time. If we look at the COVID prevalence today, the 11th of June, it's changed a great deal. And so it perhaps could be important to continue to overlay data on these factors as we go forward. And we have data not only at the national level, but subnationally. So for example, in Nigeria, in May, the COVID prevalence was more in the south, which is less poor, but in the north, where poverty is higher and risk factors are higher, the course of the disease could be quite different in health terms. So we just wanted to get that information in the hands of those who are doing responses. And clearly in Nigeria, there was lots of inequality within the country. But actually, if we go across sub-Saharan Africa, which is mapped here, this is a national map, there's inequality in every country. So the bubbles show the difference in terms of the levels of people who are deprived in all three of the risk factors at the same time. And you see there's no country, very few countries that have very low inequality within the countries. And that means that health responses will hit different communities differently, depending on the additional burdens that they are carrying. Now we're moving to South Asia. And if we look, for example, at 4 countries, Bangladesh, India, Pakistan, and Nepal, and we look at their subnational areas, we see that Nepal has much lower inequality than others. But you also see India, the inequality is not only by geographic region on the left-hand side, but also by caste, with the scheduled tribes being the poorest on the right. But so far, we've just been using the 10 indicators that I mentioned. But in our database, there are also other indicators related to COVID risk. For example, do they have a place to wash their hands with soap? Is there overcrowding, more than 3 people, for example, sharing a sleeping room? Do they have access to internet? Is there domestic violence? And what we can see is that across these 4 countries, if you look at the poor people, multidimensionally poor, and compare their deprivations with the non-poor, they are higher than the poor, particularly in hand washing, overcrowding, and internet. And in 3 of the countries, domestic violence was higher among the, although in Bangladesh, it's about the same. So with an understanding of the variables that are of interest in the policy environment, we can bring in and map additional relationships that might be of particular interest, and also policy relevance in containing the spread. But many of the survey data gathered before the pandemic, surveys are now paused. And so we also need to recognize the new deprivations that are coming in and pushing people into poverty globally and nationally. And so for that, we are at the moment either using microsimulations to estimate future trends, or where there are remote rapid surveys, incorporating these new data into the data environment. And so, for example, in projected increases in hunger or in children out of school are things that we do and can capture. So I'm going to shift now and show you some examples of that, but moving back to national measures. Governments tailor multidimensional poverty measures to their own context, their data sources, their political priorities. And so what many countries are doing is extending the existing official permanent poverty, multidimensional poverty indices to look at vulnerabilities to COVID. So for example, in Afghanistan, their MPI release in 2019 has 5 dimensions that include health, education, living standards, work, and then shocks, income and production shocks, violence shocks, and natural disasters. And 52% of the population were multidimensionally poor. But then we can do microsimulations because there is, unfortunately, a rise in hunger, loss of employment, and children out of school in Afghanistan. And so the vulnerability analyses there included these microsimulations. If we turn to Pakistan, Pakistan did not have up-to-date census or registry data, nor up-to-date survey data, whereas Afghanistan's was 16-17, so pretty okay. And so Pakistan created a multidimensional vulnerability index using older data to look across their districts and see which ones were likely to be most vulnerable. But then they opened a demand. The Asas Poverty Alleviation Program let people SMS in their need for support, and then cleaned that database of millions of responses, whether the people had a car, paid income tax, etc., to rule out people who were not likely to be so vulnerable. And then they were able, using increments of their existing lists, plus the new demand responsive lists, to offer emergency assistance. In Bhutan, it's one of the many places now that are exploring telephone surveys. And this first exploration was with the tourism and allied sectors because the borders closed and all of the tourism sector of Bhutan, of course, became instantly unemployed. So we did a multidimensional vulnerability index using that rapid socioeconomic impact assessment tool, finding that 80% of the workers in the tourism and allied sectors were deprived in at least 3 core vulnerabilities. And we looked at their coping strategies, their interest in retraining in education, and also their care burdens at home. Was there a pregnant person, a person with disabilities in their household, an older person? So these rapid surveys, again, bring in some different kinds of information that complements the more direct health data. And so the last country example I'll give is Colombia. Colombia, which has had a multidimensional poverty index nationally since 2011, had a recent census, and they include data on their MPI in their census. And so they also obtained permissions due to the pandemic to be able to blend health record data with the census and do some kind of overlays of data that in normal times perhaps are protected by ethical standards, but was quite important to contain the contagion. And so they started with a basic map of multidimensional poverty, drawing on census data. And at the block level, they created maps. And these are online on the website of the National Statistics Department, DANE, for the government. And then within 2 weeks of the pandemic striking, they were able to blend those data with administrative records and a living standards measurement surveys to create vulnerability index. And then they added also health records data in a separate exercise and information on government programming. So for example, here's a map also of Bogota, stepping back a little bit further, but now including multidimensional poverty and vulnerability from additional data sources, and health centers, which are the blue dots. And so that is quite a useful target in order to continue to keep a track of the pandemic. And other data interfaces include the contagion and data on the health contagion for 1,100 urban municipalities. So what is needed to keep this momentum going forward? And I'm glad we have a blended group of health and poverty people One is on the poverty side, we need to try to include more COVID vulnerabilities or pull them out of existing data sets to identify the people who may become the new poor, and also to map public health facilities and systems over poverty data, but also to innovate very actively on data collection, to be able to see, who is at risk or suffering from the pandemic and what kind of deprivations do they carry. And so that means including MPI indicators in rapid remote surveys, including health and poverty data in the same data set, so you can see who are the same people at that level of precision. And of course, integrating MPI into the 2020 census round, and also ensuring that the responses to the pandemic consider the poverty status and character of poverty of different communities. And so that's really what I wanted to share. I'll end with 30 seconds of hope. Between December 2013 and March 2016, Ebola struck Sierra Leone. But in the study that we'll launch in July, we find that using a data set 2013 to 2017, of 75 countries, Sierra Leone had the fastest reduction of multidimensional poverty of all 75 countries. And this was during the years of the pandemic. And we know from talking with colleagues who are on the ground that responses were not perfect. They were made with galloping speed, there was human error, and there was tragedy. And yet it does seem that perhaps with a concern for equity, there might be space to maneuver. And so predicted increases in poverty don't occur. And perhaps indeed, they might come down a bit. Thank you so much.
Thank you very, very much, Sabina. That was perfect and on time, as you show me, and opens up a whole set of issues around the link between poverty measures and policy, but also finishing with a positive spin is particularly important in this time and age when we are not all very optimistic about the world. So let me move to Rishita first, and then Ernestina for a discussion that is more about health.
First, thanks so much for having us. I'm really excited to hear people's reactions and comments to what we have to present today. I think first, responses to the pandemic highlight the complexity and the interactions between the biological, behavioral, and social risk factors. And I think a lot of lockdown measures, for example, have quite severe consequences for access to a range of healthcare services and for service provision. And in this presentation, Professor Coast and I draw on our previous research on sexual and reproductive health and abortion in particular to explore implications for women's health in COVID-19 times. What's evident is that COVID-19 has exposed the fault lines of health systems, that they're underfunded, under-resourced systems that are contending with a shortage of equipment, a shortage of staff, and this is staff at all levels of the system, and that it exacerbates existing inequities in healthcare access and in provision. Even before the pandemic, there are very critical gaps in access to sexual and reproductive health information and services, with a variable quality of services and care available across different contexts. And some of the preliminary reports and models that we have at the moment show us that states' COVID-19 responses may lead to an increase in unintended and unwanted pregnancies. And this is partly due to diminishing reproductive health supplies and their availability, which is also because of an impact on the reproductive health supply chains themselves because of lockdown measures. We're also seeing an increased incidence of intimate partner violence and rising income insecurity. And access to health services, particularly those that are stigmatized like abortion, are mediated through and shaped by individual characteristics such as age or marital status or caste, as we saw in Sabina's presentation as well. Now, exploring access to sexual and reproductive health services lays bare the ways in which it is influenced and affected by social norms and beliefs, such as stigma or very strong gender norms. It's influenced by gendered relations, such as decision-making, who is the final decision maker in the household, or notions of care work, who carries the burden of the majority of care work in the household or in the community. and as well as existing laws and services. So for example, the legality of abortion, or who is allowed to provide certain services and under which conditions. And focusing on sexual and reproductive health highlights how pandemic responses can often individualize responsibility, and without tackling the larger structural inequalities and inequities that shape and mediate people's decisions and choices. Sexual and reproductive health is fundamental to people's health and survival. It's fundamental to economic development and to the well-being of people and their communities. And they need to be considered within pandemic responses as essential services. But these are too often at risk, as we see in the US with the current attempts to locate abortion as a non-essential service, for example. Here in this tube station-like map, we see COVID-19 has both direct and indirect impacts on morbidity and mortality. And we know from previous health emergencies like Ebola and Zika that there are indirect morbidity and mortality impacts for sexual and reproductive health as well. Access to sexual and reproductive health services can be severely disrupted during outbreaks, disempowering individuals, particularly women and girls, and exposing them to preventable health risks if those services are not available. In the Zika virus outbreak, for example, differences in power between men and women often meant that women did not have autonomy over their sexual and reproductive decisions, which was then compounded by inadequate access to healthcare and insufficient financial resources to travel to hospitals for seeking care or move closer to the family or other support networks for quite crucial amounts of support or help that people may desire. And this is exacerbated when we also account for the fact that women were often doing most amount of community-fed control activities. And we see similar things reflected in the role of lay community health workers and their involvement in community contact tracing during COVID-19. I'll hand over to Professor Coast now.
Thanks, Rashita. So returning to these points, whilst Rashita and I are looking specifically at these issues through the lens of abortion and abortion-related care, it's worth situating within the broader field of sexual and reproductive health and thinking about what we know already, what we can learn from other health emergencies, for example. So for women who are pregnant and delivering, for example, we know there are profound knock-ons in terms of either the availability of or the access to services. So the realm is much broader. We're looking at a narrow focus through abortion. Another critical point to draw attention to is the issue of inequities. There are well-established inequities within sexual and reproductive health globally. We know that some groups have distinct SRHR needs, and we can see the way in which COVID-19 lays these bare. There's evidence coming out of South Africa, for example, about how female sex workers have been impacted by the lockdown and what that is meaning in terms of their livelihoods, what it's meaning in terms of the prices that they are able to negotiate for their services, and importantly, what it means for their ability to access the care that they need. Next slide. One of the reasons that we focus on abortion is because it allows it, well, one of many reasons, but one reason in particular is it's a very distinctive form of healthcare seeking behavior. It has 5 characteristics that make it, we argue, unique. First of all, it's legality, which varies across contexts and for some countries within countries. Options for different levels of safety of abortion are strongly determined by gestational age, which means that delays and timing are absolutely critical to direct and indirect morbidity and mortality health outcomes. That abortion is an episodic event in people's lives. It's highly stigmatized irrespective of the legal setting, and it's something that only women receive. That is not a misspelling of women, that's acknowledging feminist intersectional approaches to understanding the word women. Next slide, please. So what we've been doing is looking at how we can take existing frameworks, and this is a framework that I developed with colleagues, in order to understand what are all of the things that we need to take into account as explanatory factors in order to understand individual trajectories to abortion-related care, whether or not that's safe care or least care, or least safe care or less safe care. And next slide, please. The question is, what happens to holistic frameworks like this when we overlay COVID-19? So what I'm going to do in the next couple of slides is to look at specific aspects of this framework, which Rashita then extends in her own work, and ask, what does this mean for abortion-related care when we have a health emergency, like COVID-19? Next slide. So a critical point is awareness of pregnancy or confirmation of pregnancy, and they're not often contiguous in time. So we know, for example, that COVID-19 is impacting already on people's abilities to confirm a pregnancy, and importantly, whether or not they have to keep that a secret, reinforcing something that Rashita said. We know that a lot of abortion-related care, for a variety of reasons, is highly secretive in many contexts. We see intersections with age. We know pre-COVID that adolescents are much more likely to have later pregnancy confirmation and awareness than older women, and that is only going to be exacerbated. Next slide. I'm just going to jump around in the framework to draw out some illustrative cases. We know it is well established that there is either called a shadow pandemic or a syndemic of sexual violence. So in terms of exposure to risk potentially of unplanned pregnancy, we know that that is strongly linked with lockdown and quarantine measures. There is some evidence emerging out of settings here, drawing on the work of Niavani Madize in Malawi, where school closures as a result of COVID-19 appear to be signaling some changes in marriage patterns, possibly earlier marriage patterns for girls in terms of their exposures to risk. Next slide. And looking at the macro or the more structural context, we can look at this at the global level. We can see profound implications for the global commodity supply chain of contraceptives. That's having a huge knock-on effect already. If there is a small positive to maybe think about, it's the ways in which a health emergency can provide a lightning rod for innovation in healthcare. Remarkably, we saw that happening in the UK as COVID-19, well, not across the whole of the UK, so far only England, Scotland and Wales, Northern Ireland lags there. In terms of the provision of telemedicine for the self-use of medical abortion, we're seeing this in parts of India. We're also seeing it through often feminist collectives providing these sorts of services. But we can see increased pressure on healthcare workers and what that is meaning in terms of people being unavailable to provide SRH care and services, but also fundamentally we're seeing the closure of services. Bearing in mind that COVID-19 in the realm of abortion-related care comes on top of, for example, the impact of the so-called global gag rule in many parts of the world. Back to Rashita.
Yeah, as Anastasia says, I think it's important also to always remember that abortion is extremely time sensitive, and that any delays in care seeking and provision will profoundly impact not just your trajectories, but also your overall experience of care and whether you can actually receive abortion care or not, depending on your gestational age as well as legal conditions in place. So in my research in India, where abortion is available on broad legal grounds, my findings show that there are quite strong delays in pregnancy confirmation, in procuring accurate information, and access to health services, all of which negatively impact women's abortion experiences and their outcomes. So in terms of how safe it is, in terms of the kind of disabilities or morbidities or mortalities they may experience. And when women experience delays or barriers that they cannot overcome, they may then turn to unsafe methods of providers, which have these profound consequences for their lives, but also for that of their communities. Picking up on and reiterating the point around secrecy, one of the key elements in my work and that influenced women's trajectories profoundly was this desire for secrecy, because it exacerbated delays as women attempted to identify providers without revealing their pregnancy or the fact that they were considering an abortion. The other thing my research shows is and underscores is just how essential frontline health workers are. In India, you have a cadre of health workers, of lay community health workers called the accredited social health activists. These are women from the villages. They have about 2 weeks worth of training. They're not medical professionals, but they are the front line of the Indian health system. And they're essential. They play really essential and crucial roles in women's abortion trajectories. They're equipped with pregnancy test kits, so they're often present at women's confirmation of pregnancy, which is why in my sample we also saw women, or the majority of the women in my sample had quite confirmed their pregnancy very early in gestation, which gives them a longer amount of time with which to negotiate these delays in order to access abortion, and gives them the range of pregnancy options. ASHAs also play quite essential roles enabling access to abortion through information provision or referrals, all of which can help mitigate delays. And one of the most important things about their roles is that they're seen as trusted confidants or elders from whom you can seek advice. And in COVID-19, this role has become even more crucial. So in one reported case, a woman and her partner were traveling to an abortion clinic and they were stopped by police officers because of lockdown measures. And they were only allowed to continue their journey after contacting their local ASHA worker. But COVID-19 has also dramatically affected ASHA's roles, with travel challenges and suspension of take-home resources such as these pregnancy kits. And the lack of access to a pregnancy test has then meant that women's pregnancy confirmation is delayed, which affects the reproductive health options that they now have. Women may, even if they are then aware of the pregnancy, decide to keep it secret, given lockdown conditions, attempting to minimize the number of people who would be involved in decision-making, and try and avoid protracted negotiations while they try and work out another way forward. And apart from the disruption of routine care, ASHAs have been tasked with additional COVID-19 duties, such as community contact tracing, which has affected how ASHAs themselves are viewed. Concerns about whether they can transmit infections or are carriers can mean that they're no longer seen as trusted community members, but are seen as a risk, which removes another crucial pillar of support. This pillar of support for information seeking, for emotional support, or for more practical support, of referrals or procuring medical abortion pills for self-management. All this to say that sexual and reproductive health and abortion need to be understood as essential elements of a COVID-19 response, but it has to be one that centers the needs of women and girls and of marginalized groups in its response. It needs to account for and reckon with people's lived realities, the complexities of social norms, of people's fears, of decision-making and how that manifests. All these responses risk being really inadequate and ineffective measures.
So to draw this together, this is a deliberately simplistic slide about thinking about the connections between health more broadly and poverty, or specifically abortion and poverty. We know that poverty is in and of itself a driver of exposure to risk, of having a less or a least safe abortion. We see that in the evidence time and time again. But also importantly, poverty is also an outcome of indirect morbidity and potentially ultimately mortality resulting from abortion or abortion-related care. And it's really important that we keep both these cause and consequence factors, or the bidirectional relationship between COVID-19 indirect morbidity outcomes and direct drivers of poor health outcomes. So I'm just going to finish off by returning to our final slide, or not, which is that COVID-19, we've used the lens, a very small and specific lens of abortion-related care. But what it's doing is it is really, to reiterate, exposing these fault lines and exacerbating inequities and exacerbating them across intersections that pre-existed COVID-19. Thank you.
Thank you so much. That was extremely interesting and rich and very different to Sabina, but at the same time complementary. So I wonder now whether people have questions. You can ask them, I think by primarily in the questions and answers and the chat. Although, at least in another web that I was, you can also, no, I think you cannot raise your hand. So let me wait for either questions in the chat. Ah, here it is. No, this is. Okay. Meanwhile, while I wait for questions and comments from the audience, I wonder whether I can ask Sabina a couple of questions. The first is, of course, I was left with a positive story, wanting to know more about why, right? So why it is that that happened, and what are the lessons you think that we learn from the others. But the second is one that worries me always, which is the combination between the short run and long run. So we are always now very worried about how we respond in the short run and how we build better indicators. Could you, based on your interaction with governments, tell us a little about where you see positive interactions or times where the short run will clearly be beneficial for the long, and where we are actually having very short responses that are unlikely to do very little for long-term debates? And then we have a question for, I think, both of you in a way, which says, although primarily for Sabina, in the first presentation, the speaker spoke about inequality and COVID transmission. However, in the sub-Saharan Africa, with simply poor poverty indices, the transmission has been relatively low. And whether this connects to our conversation 2 weeks ago, where you can offer some lessons for that, some explanation, sorry. So Sabina, the floor is yours.
Thank you. Yes, in terms of the short term versus long term, I think what's very clear is that in the short term, COVID emergency responses were undertaken often during a lockdown. And so they were really confined to cash transfers, or in some cases, food transfers, and of cash, but not addressing services or structural causes. And it was perhaps also not addressing some of the populations that were excluded from the systems. I think that there's also a need in some countries where hyperinflation has taken off to think more about controlling food price shocks, especially because the cash transfer was to cover an amount of food that it would buy when it was planned, and then with inflation, that amount of food has gone down. In terms of the longer term responses of strengthening health systems, of getting children back in school, qualities of restarting school lunches where those are essential both to students and also to improve their nutritional outcomes. A lot of those are simply awaiting the next phase. And so the hope is that the resources, so the emergency response is just about, which is not, it's a huge just, it's very important. It's also about, in some countries where they've been able to target informal workers who lost their jobs, stabilizing their lives. So preventing some of the predicted rise in poverty. For the next phase, we'll have to think about, okay, there will need to be stimulus to restart the economies and to get people back into work. But would there be a way of also getting them back into the kinds of jobs that will create infrastructure and service strengthening that would simultaneously reduce poverty? And so these interconnections are quite important. quite vital. And I think they really do have to do with employing the recently unemployed. In terms of the second question about, so we are data users. We don't collect data ourselves. And so a lot of what I showed you was using data that was collected before the COVID period. So all of the global MPI data, for example, is before, and all of the national MPI surveys, because household surveys are paused. And yet we reanalyzing them and bringing in other variables, intergenerational households, informal work, overcrowding, hand washing, these things in a different way, you can say, well, before COVID hit, this district wasn't poorest before, but look, when we consider these other variables, it is. Or for allocation of resources, you can anticipate the changed map, which is the vulnerability work that everybody basically has done, reanalyzing existing data. Where there are new data, and the data come either from telephone surveys, from administrative data, from health facilities, where they are having registry data of different kinds, then these can be used to supplement. There are simulations of projected increases that come from different agencies focused on particular indicators. You can use those. World Food Programme has different predictions, given the droughts, given the COVID, lots of intervening factors for 50 countries, certain subnational regions, and predicting the increases in food insecurity. We then use those as data users for microsimulations. So that's, in a sense, the conversation across people with different specialities. So I think it's fair to say that data collection is not right now, but where it is happening, we're trying to make the best use of the scarce resource.
Thank you very much. So we have 3 questions now. Another for Sabina, but then 2 for Rishita and Ernestina, and 1 for all. So Nimesh asked, beyond rapid surveys, Sabina, what alternative forms of data collection assessment can we think of, understanding new forms of vulnerability and deprivation? And you touch on that a little, but maybe you can extend. Ernestina and Rishita, for countries in which abortion is not being considered an essential service during the pandemic, will the research currently being done regarding the issue have the ability to create change to these policies in real time? So it's about the research policy overlap, which is always complicated. And the last one is from someone that came late. So it's a general question. How do you assess the impact of the ongoing crisis on the achievements of the UN global goals in the most vulnerable countries? And I guess we could amplify this in terms of health to a specific role of women's health and abortion as well. And how do you think this could be affecting, and is there any way to think about this positively? That's my addition to the question. So maybe Ernestina and Rishita, I can start with you this time and then move to Sabina.
Thanks for the question. I was just looking at the question, sorry.
Oh, sorry, I moved them to answer. So if you go to answer, I apologize.
No, that's fine. Yeah, I think there's a few things here. One, I think in countries where it's not been seen as an essential service, there is a huge push from a lot of women's health organizations and a lot of feminist organizations to see this policy shifted and to have conversations, particularly around, say, access through telemedicine and what that might entail, or attempting at least to have certain restrictions lifted in times of emergency. Whether those have traction at the moment is variable. So, for example, in Brazil, that hasn't had as much of an impact. In India, there's ongoing conversations around providing abortion through telemedicine. So I think it depends, and I think it also depends on the sort of policy situation you're already beginning with. So in the US, with the increased restrictions around abortion, we're seeing sort of a heightened attack in that context, while in other, so even in the UK, where there's been a conversation around liberalizing it further, the abortion law, this has been an opportunity that people have been able to capitalize on. So I think within the research policy nexus, there is the larger context of who are the actors operating and the ways in which they're able to mobilize resources and the momentum with which to enact change. I don't know if anyone wants to add to that.
Thanks, Rashida. Yes, I think we can look more broadly at the way in which health emergencies are framed. We often see a strongly epidemiological, correctly so in many ways, framing, but it's done at the expense of other framings. Rights-based framings that take account of gender. We saw this in Latin America during the Zika health emergency, and working with colleagues, we've been looking at this in El Salvador, Colombia, and Brazil, and we see the effect of the Zika pandemic the Zika health emergency was negligible in terms of the regulatory or the policy sphere. And in fact, a lot of people were using language of saying, that's just a feminist issue, that's just a women's issue. So, you know, this framing of health emergencies is profoundly important. And I would argue we're seeing this again with COVID-19.
Thank you very much, Sabina.
Thank you so much. Rapid surveys by phone are one option, which is problematic because perhaps we need to rethink, not all countries have telephone numbers for a representative survey. People don't have battery charge. It's difficult perhaps to carry on a conversation for half an hour even. So it's a constrained environment. They are also doing surveys on apps and SMS. So what's been interesting has been national statistics offices working across the aisle with private sector groups who are used to marketing surveys in remote areas. And so cross-learning different techniques. So trying to improve the sampling, but also learn the faster data responsive mechanisms. And there obviously with the health systems and with the patients, then there are registry data and also where people are collecting cash transfers and other benefits, then sometimes they also have a system of collecting updated data, not always. So I think it just varies so much that we are learning as we go along, but it's clear that many of the international institutions are investing in this very seriously and trying to make it a time of going forward. And as I said, in the case of Colombia, there's a two-edged sword because they've been able to merge for the first time very different kind of administrative data by the House ID of the person, which has privacy concerns, but it gives very granular data that's actually very useful in this particular context. And so thinking through those privacy issues as we go on, I think is really vital so that we protect people and yet have more data at less cost, which would hopefully make the response more effective. In terms of the SDGs, so there are different predictions, and we are doing our own with UNDP that will come out in July of the numbers of years that COVID is setting us back in terms of the decrease, the trends in multidimensional poverty reduction globally. But we've done some at the country levels. And so it's setting people back clearly in different SDGs related to nutrition, related to employment, related to child school attendance. Those are very, very direct impacts. But another is the urban-rural migration. Many people are migrating back to their villages. And if you think of migration is a wholesale shift in your living standard. And for us, 4 to 85% of the poor people live in rural areas. Living standards of housing are lower there. And so that also creates a whole shift in the deprivation profile of the returning migrants to the rural areas. So there are a number of features that will make some of the SDGs more difficult. There's also the very sad fact that when people perish and they are poor, poverty goes down. So poverty is blind to people who die. The numbers are not big enough, thank heavens, so far to make that overcome the numbers of people who are increasing in poverty. But I think it's a complex field and we're trying to sort it out, but it will take some time.
Thank you, that's extremely useful. So let me go with another 3 round. So the first one, in the context of countries without universal social protection or universal health coverage, such as the case of India, is the use of a strict lockdown a good idea? This is not something either of you trade directly, but obviously has relevance on some of the debates you were saying. The second is from Omasunjewa Idun. Sexual and reproductive health and rights issues are usually not given the appropriate priority, and they are likely to be further relegated at the background during outbreaks. Are there any policy suggestions to help this? And should each country not institute lockdown measures as it applies to their context rather than copy and paste? And this is thinking on India and Nigeria, for example. Then Sabina, of the many impacts that you talked about, those on the informal sector and casual labor, or those from the lower classes can be disproportionately affected. So you mentioned that getting back to work, it was necessary, but the current situation makes this difficult. Should government think of alternative ways to redistribute resources? For example, taxation of the rich. I think also, obviously, social programs that you have already worked on and even make proposals. So maybe you can tell us about that as well. And finally, from Joe to Rishita and Ernestina, regarding the framing of health emergencies, what are your thoughts on the response or lack of response of the WHO regarding this specific problem that you deal with of abortion? Again, maybe I can start with Rishita and Ernestina and then go to Sabina, if that's okay.
Yeah, I think the three questions actually dovetail really well together. I think around the question of policy suggestions, and I'll start there first, I was actually going to say, well, I think, which also sort of responds to, I think, to Joe's question, is I think the WHO response, the WHO has about 2.5 weeks ago put out their update on COVID-19 guidance around health services, which has included abortion. Obviously, with the caveat where legal or in context where it is legally available, should shift to using telemedicine or consider how it can make abortion available. And to think about this not just in times of COVID-19, like in the middle of the pandemic, but also for when we're coming out of the pandemic and the resilience of the health system itself. So I think this is one way in which it can allow health systems to respond and allow governments to think about the range of issues that should be focused on. Second, I think what it does is that it reiterates one of the core elements of the current policy guidelines that we have in international documents, particularly that even where abortion is not legal, post-abortion care should be provided. And I think in sort of picking up on what Ernestina said around health emergency framings, how emergency responses might allow us to think about what constitutes the range of abortion care. So I think that is another way in which the sort of policy responses around sexual and reproductive health can help and to have some pressure from the WHO. Now, questions around the legitimacy of the WHO and its continued role in health governance also come up, but for me, I think it remains an important part of their role. Do I think they could do more? Certainly. Do I think they could be more direct? Definitely. In terms of institute not having sort of copy-paste mechanisms, I think, especially for developing country context, and I think this responds both to the second part of the question and Harry Caitlin's question. I think in a lot of low middle income countries, family is quite a crucial support space, and it can be quite crucial for survival itself, whether that is pooling household incomes together or providing advice and information, childcare, if people need to go out to work in as community health workers or anything, like the range of employment options that might be available to you, and the ways in which family steps in. And I think if lockdown measures are being imposed, then governments also need to be thinking about what are the support mechanisms that are now lost, and how do we account for them when we impose measures like this? How do we account for the ways in which the very essential pillars that surround people's or allow people to survive have now been dismantled. So I think that if we are going to impose lockdown measures, then I think that needs to be accounted for as well.
I'll pick up on that. I think one key thing has been this incredible emphasis on the household, and we see a lot of elision in terms of the use of the language around what's a household, what's a home, and what's a family. And we know, be it in terms of financial resources, food resources, childcare, support from somebody who can keep your secret if you're trying to get an abortion, these are not neatly contained by households. And I know it's one of the things that people using household-based data, really struggle with and have to contest. What is a household, but really importantly, under a condition like a health emergency with a lockdown or a quarantine, what does that actually mean for how people live their lives, whether or not, regardless of what resources people are trying to get a hold of? Thank you.
Yes, no, and thank you again for the interesting answers of the others. I find that fascinating. So in terms of lockdown without health protection, I think we know that that there's a tragedy, and that any of the courses of action of the complete lockdown or lack of lockdown will have a terrible impact, and in both cases the impact would be larger on the poor. And so the question is, what is going to be the optimal balance? And the further issue is that we don't know. We're learning. There's a lot of uncertainty, and I don't know. And so I can't claim to have particular expertise. And the concern is very much that in some places where lockdown was implemented immediately without the possibility for people to go and buy food stocks, the devastation was huge and not fair, but it was also quiet, because people were within their homes. And I think the further complication is that if this continues, then it will probably cease to be quiet and become political, and we will see more unrest than we have so far. And so I think it is a balance, and recognizing that we'll have to learn from what works and try to adapt it in other places. So it's not necessarily dodging the question, but it's trying to say, okay, there needs to be parts of both, but without a lockdown, we know that the poor will have a greater exposure to the virus, but with one, they will have a greater exposure to other very, very significant tragedies, because they won't have jobs and they won't have reserves. And so just having the concern for threading through whatever policy responses there are is a little bit that we can comment on. In terms of the labor, there are questions. Work with safe social distancing, but for example, there are strong calls in India to reignite the NREGA, National Rural Employment Guarantee activities to put people back to work, and so that they have productive jobs, and so that they have a family and a kind of exchange. And so it's not perhaps out of, but it needs, just like all of us going back to work need rethinking issues of social distancing. The return to work will need that cases as well. But in terms of taxation of the rich, that's certainly part. But I think a really exciting part is also to reach out beyond the government to private sector and to philanthropy. But in the case of private sector, we have a social enterprise. It's quite interesting that a number of corporations are trying to say, well, what can they do? What can be their response with their employee base and with their value chain to try to, redress some related impoverishing aspects of the pandemic. And there are also other organizations that are trying to, for example, have corporations buy vouchers that can be distributed to people, but the vouchers are for cooked food in restaurants with appropriate social distancing, so the restaurants buy supplies and employ people. And so the voucher for the poor also jumpstarts parts of the service economy. So I think thinking about these interconnections and finding a sweet spot where it exists is also another avenue of exploration.
Can I?
Rashida, yes, of course.
I was just thinking about one of the questions that was asked around the use of strict lockdown and whether that was a good idea, especially if it resulted in more number of deaths due to COVID. And I think just coming back to one of the points in our presentation is it's not just people dying of COVID, it's how the lockdown measures have exacerbated or have been put in place in such a way that they have caused or resulted in the deaths of people who didn't die of COVID, but because as a result of the lockdown. And I think we need to account for that as well in the kinds of measures that were placed and the ways in which they were put in place. So for example, in India, if the lockdown measures were put in place and migrants are walking from New Delhi all the way to, walking for 6 days to get home, because of the lack of planning or the lack of measures put into place to consider what are people's needs, where do they live, what is the household for migrant workers in the capital city. And I think we also need to be thinking about, when we talk about COVID-related deaths and what were the policy measures in place, that we account for these larger conditions as well.
So to continue the war metaphor, we don't just want to know the deaths of combatants, but also the collateral deaths, very sadly, and the collateral impacts. Yeah, well put.
I mean, I obviously agree, but I think this point is very well taken. That is not about the lockdown. It's not about discussing whether the lockdown was needed or not, right? But how it was imposed and with what other conditions. I think that we should all try to avoid lockdown yes versus lockdown no, which doesn't take us anywhere, versus how do you complement it with what measures, how you organize, how you plan it, etc. Any other?
I can.
Yes, Ernestina, of course.
Add to that, and I think there might be more questions coming in the chat rather than the Q&A at the moment.
Okay, perfect.
I think we need to take a really good look at the assumptions that underpinned where safety lies, or where safety lay for people. Assumptions that the household, the family, the unit represented a place of safety. These concerns were being raised as COVID-19 was emerging, with people saying, look at what happened under Ebola, look at what happened in some contexts around Zika. And there's been a very delayed, if any, response to acknowledging that for all sorts of people, including children, that the household is not a safe space to be in. And I think that is one of the really difficult things to consider. But what is not contested is that previous experience was essentially ignored in the imposition of what people are referring to in a very binary way as kind of full lockdown or no lockdown.
Perfect. So Ken, I think can you simply ask, so if you can, yes, so why don't you ask the question and then I will read a couple of the others that are in the chat. Thank you, Ernestina, for telling me that they were here.
So Diego, you don't want me to write my question down and have you read it out for me? Yeah.
No, I think your English is actually much better than mine.
So I have, it's a pair of related questions about SRH and abortion for Rashida and Ernestina. They kind of build off the question that Joe asked in the Q&A a minute ago, and that is, I guess the questions are there any, quite simply, are there any helpful global actors? I mean, so a lot's been made of the WHO being sort of hamstrung and unwilling and unable to step in. Are there any helpful global actors? And the other question I have is the US ever helpful? In other words, I know that every time a Republican and Democrats come in, the first thing that they do in the White House is symbolically is either introduce or eliminate the gag rule. But, and there's a lot to be said about the current administration's foreign policy on all sorts of issues, including SRH. But is there a reason to think that if basically we had not just a sane Republican, but a Democrat in the White House, that the US policy would be different on this? And when I mean that in a serious way, like to what extent is the US ever a helpful global actor on these issues?
Thank you so much, Ken. And if I can add, so a question to Sabina, which is in the chat. Sabina is, whether the burden of procuring so much data so quickly during the pandemic could actually be in contradiction with the struggle of collecting routine data in some of these countries, and whether you see a trade-off or whether you have been able to do this in a complementary fashion. in many ways. So let me start with either Ernestina or Rishita and then go to Sabina.
This is where we both look at each other and say, Ken, really, what a set of questions. Okay, around your question about are there any helpful global organizations? I'm gonna come at that from an angle. I think what often gets ignored is the community level, whether or not that is community on the ground in real life or community transnationally over the internet. Because certainly what I can see is, as a spectator of that, is incredible work being done around activists, often but not always feminist activists, across different sorts of legal settings, being able to use tactics and techniques irrespective of nation state borders in ways that does increase and improve access to some services. In terms of, you know, you're American, I'm not going to answer a global question about the US. I would certainly say in terms of under times when the global gag rule is not being reimposed, if we look at what happened under Obama, for example, and the extension around thinking about more broadly around a rights-based agenda around SRH and getting it out of a purely kind of public health lens, I think that was very powerful.
I'll start with the second question, I think. Is it ever helpful? I think this is a particularly bad time. Because it wasn't just the imposition of the global gag or the reimposition of the global gag rule, but it was enhanced. And so what it covers is, I think, unprecedented, and or sort of restrictions in place now, that wasn't the sort of gag rule that we've had under presidents past. So I think people are really reeling under the imposition of these really strict rules that can be interpreted in so many different ways that are now restricting the kinds of services that people can provide, or that organizations and countries can provide. So I think there's that element that I feel like this is a particularly bad time. And I think just globally, I think we're seeing a lot of abrogations of rights and a lot of the rights language that was really fought for. And I think, picking up on what Ernestina said around activists at the moment, but this is also a fight that began a really long time ago. So all of the language that we have around abortion now came from community level, came actually often from the global south, arguing that this is the sort of language that we need, these are the rights recognitions that we require. And I think that has been in some ways and sometimes facilitated very much by UN agencies. So within abortion rights language, and we're talking about documentation, if we talk about the Cairo Consensus in 1994, that was in many ways facilitated by Nafi Sadiq at the UNFPA. And so on, even for the Beijing Platform for Action and the Vienna Convention, all of that came at this, I think, at a time where it was really working between community level activists or your regional activists and your UN agencies. And so I think perhaps some of that still exists in some forums, but I think there's been an increased disillusionment where, okay, at this point, we're not actually moving forward. We are now just trying to protect the rights that we have. And we see that at the Commission on Population Development resolutions or the Commission on Status of Women resolutions, which have at this point just been hold the status quo, because we're so afraid that we're going to lose out on what we have already. So I think people have turned to look elsewhere, which is the systems are not helpful. So how do we organize through thinking about self-management of abortion through our hotlines and so on? So I think that's where the shift has been now.
So Sabina, before you answer, Ken, is your question a follow-up directly, and would it make more sense for you to ask it now, or should I?
Yeah, it's really just a comment, and it's directly responding to Ernestina's reply to the question that I asked about the U.S. position and how it might or might not change depending on the character of the person in the White House. And that is that if the World Health Assembly in May with the resolution on sort of the global solidarity response to COVID, there's two areas where the US objected. One is sexual and reproductive health. The US objected to the language on that. And the other is the area about language around intellectual property over vaccines and therapeutics. And so Ernestine and I have commented before that like both of the things that we care about were basically redlined or struck out by the US. But the point is that if that same resolution were taking place, what I hear Ernestina saying is that if that same resolution were taking place 6 years ago, the US maybe wouldn't have reacted the same way. If that same resolution were taking place 6 years ago, no matter who was in the White House, the US would have reacted the same way. So I think there's something interesting about sort of that these are the two issues that the US seems to be obsessed about, but one of them they're always obsessed about, and the other one does seem, that might actually give sort of a way of essentially addressing that question about how US policy changes.
I'm looking at Ernestina. I don't know if you have a follow-up. No, Sabina, please.
Thank you so much. So just a couple further things on data. One is that many countries have a 2020 census coming up anyway, or they are gathering other information anyway. So the ask is not to do new data gathering, but to make sure that the data that are gathered are fit for purpose in this new context in terms of having relevant poverty data where it can be blended at the micro level, at the level of the person or of the household where we can't. So that we can look at the overlaps and see the sort of holistic picture of their lives. But I think two other examples. One is somebody in the chat mentioned Nigeria, and having an app in Nigeria, which they will do for multidimensional poverty, will also be able to sort of ground how poverty has changed and how much it has increased. And without actually having data on that, it's all speculation, it's all simulation. You don't actually know. And so the government or other sector responses are a little bit hampered until you actually know the scale of the problem that you are addressing and its distribution. And the final thing is to say that sometimes it's really quite important to inform the response. So in the Bhutan tourism survey, they also asked what people were planning to do because they're not going to have tourists there. So they have to retrain. And what was terribly interesting for them is that these people who were in hotels or restaurants or in the hospitality sector, they wanted to go back to many of them. That was the most popular profession, which had not been expected. It was expected that they would go into other services, but plumbers and electricians were a popular choice. But there was also demand for training in weaving and painting. And so as the economy sort of tried to recover, they need to know what the workforces would be energized to go into. And I think that will help the reorganization of economies because we are going into a recession. So there will be a lot of shifting, I think, in role.
So I have one for Sabina, which links to Ken's points, but in your case and about the role of corporations, etc. So corporations and banks, in the example of the US, are lobbying against direct financial aid aimed this crisis as Congress is blocking wider responses such as the moratorium on rent. How do you see such factors influencing MPI and its implementation? And a sweet spot would be great. However, it might not be. And I guess I would extend, Sabina, to tell us a little bit more about how do you see both the potential, which you were discussing before, of corporations, but how do you see actually their negative elements in some of the countries you work on, beyond obviously the US?
Yeah, so I recognize the problem sort of as a citizen, but in my own work and in my own experience, I probably don't have as much knowledge as I should about the negative influences because it happens at another level, which is not in rooms that I'm not a part of. And so I recognize it. I sort of salute that is a problem, but I don't feel I have an adequate response. What I can say is that some of the anecdotes have been about how an encounter with poor people can sometimes actually change the mind of an executive and hence have an impact on the firm. So President Santos, a visiting professor with our department, took CEOs with him to some of the poorer places in Cartagena as survey enumerators, obviously pre-COVID, to go and meet and take the survey data of poor people. And that led to sort of a re-estimation and a change in some of their practices because they had a face-to-face encounter perhaps for the first time with a peer group, all of them going out together and all of them, meeting in the evening, but able to then contain and process that kind of experience. So I guess the hope would be we could offer those spaces for solidarity, because that's something that we know more about. But I completely recognize the negative impact of the corporations, certainly on cutting aid, on moving out the positive and pro-poor's policies in favor of other policies that might benefit a particular sector or corporation. But I don't know what to do.
So I don't see any more questions. Ernestina, you were checking the chat. I don't see them either. So I'm assuming that there's none, but that we had a very nice discussion in which, again, for me, it was interesting that these are somewhat different approaches and slightly different topics, but where all kinds of implicit connections exist about the reactions that we are taking, about things like thinking about households and what households mean for different elements, and whether they mean different things for gender relations, that when we think about poverty, etc., which I think many of us can continue reflecting on. Thank you very much, Ernestina, Rishita, Sabina, for today's talk. Thank you everyone that was here with us. This is the last one, but maybe of this season. And maybe it's something that we can replicate and have more conversations, as I said, online, or if the world slowly changes, offline as well. So Ken, I'm going to give you the last word, as I always like to do, of the whole series.
Well, I'll just thank everybody today, but also everybody who presented in the previous 3 sessions. And I'll also just take this opportunity to thank Diego, because this was Diego's idea. He sent me an email as the lockdown started about suggesting that maybe we do something like this. And so we whipped up a proposal and decided to do it. And I think it's been great, worthwhile. I've enjoyed all 4 of these. And again, thanks to everybody. And also thanks everybody in the audience who participated today and in the previous ones. Stay safe, stay well, and see you all soon.
Thanks, everyone.
Thank you.
Thanks, Diego.